I'm Sarah Richardson, a principal here at This Week Health, where our mission is healthcare transformation powered by community. Welcome to Flourish, where we share the human stories behind healthcare leadership, because thriving people build thriving systems. Let's begin. Welcome to Flourish, the podcast that explores bold journeys, brave pivots, and the art of building a career that feels both authentic and impactful. I'm your host, Sarah Richardson, and I'm thrilled to sit down with Martha Lawrence, Milk and Thought Leader, CEO, and co-founder of AccendoWave, and board member of the UCLA Technology Development Group, a true quiet giant in healthcare innovation. Martha, welcome to the show.
Thank you, Sarah. Delighted to be here with you and to spend some time talking about healthcare and innovation.
I am thrilled to have you here because your background, your current journey, and all the things you're bringing to our industry are phenomenal. So let's just start there. From your earliest roles to launching AccendoWave, what motivated you to create AccendoWave, and how did your experiences shape its direction?
Great first question. So I'll start with my background and then I'll talk about my motivation with AccendoWave. So in terms of background, I spent most of my career at HCA, at Hospital Corporation of America, a company that we both have in common. And I was there for 18 years. And HCA actually incubated my company's technology. So forever grateful for their support. I spent 25 years on a payer org board. So when I was at HCA, we owned a PPO. And so I joined that board to learn the payer space. I spent a lot of time with the Milken Institute. They reach out to me as a thought leader. So I'm on employer calls, panels. I attend their conferences. You mentioned UCLA's Technology Development Group board. So that's the innovation hub of UCLA. So UCLA is our number one public university. So this is a fiduciary board, and I, along with our fellow board members, advise UCLA on IP and licensing coming out of the university, and acquisition of and investment in innovation. And lastly, I am an entrepreneur in residence for one of our federal government agencies. So that's my background. In terms of the motivation for AccendoWave, I think it really stemmed from a deep understanding of the scale of the business problem of pain. And it's really one that I think insiders in our healthcare systems understand, but outsiders, maybe not so much. And that's because we often don't tell them about the lack of data that we have around pain and really how we're addressing pain. So maybe if I can give you just a brief example. So when you're in my hospital and you can't tell me your pain, I just stare at you and I guess. I mean, I try to make educated guesses, but that's my toolbox. And so it's not something we really highlight to the marketplace, but insiders know that this is a significant strategic problem for us. And we really need to advance both the technology and what we're doing in the pain space. So that's really what motivated me to move forward with AccendoWave, and so very grateful for HCA's backing and understanding of the scale of this problem.
If you could describe for us, I feel like I should ask you what you do in your spare time, sort of cheekily, because of all the things you've got going on. But when it comes to AccendoWave's mission and innovations, especially around the data-driven scaling, your clinical and financial utility, and de-risking tech adoption, I'm just curious how all those things come together for you.
Yes, so AccendoWave is really focused on two things. Our mission is to validate pain, so your pain is believed. And secondly, to provide objective pain data and pain databases. So taking the first comment in terms of pain bias, turns out pain is riddled with bias. Both the research and the real world data demonstrate that. Bias against women, bias against ethnicity, bias against seniors. And I mean no disrespect here to our male audience, but pretty much only white men under 65 aren't seeing this problem. The rest of us are on the receiving end of gaslighting. And why that's important from a mission standpoint is that when you don't believe my pain, I lose trust. I don't trust my doctor. I don't trust my healthcare system. So it's a root cause health equity problem. So it's important to validate pain so people feel that they're heard and they are recognized with data so that we can improve outcomes. In terms of pain as a driver of cost, pain is actually the number one reason why patients access healthcare. So it's a primary driver of cost. Pain data shows up nowhere It's not in claims data. You can't actually get it out of your electronic health record. Even if you could, it would be very low quality data. And so it's actually kind of shocking when you think about it. What other industry doesn't have data on a primary driver of cost? That'd be healthcare. So that's really our focus, is having objective data around that pain conversation and pain journey. And the audience may wonder exactly how are they measuring pain? And so I wanted to just mention that now so they don't have to sort of think through that as we're talking about some other questions. So what we do is we're at the source. We correlate your brain waves with your perception of pain. We quantify the data, and then we benchmark it. And so that's what we're doing around pain data. So really a data-driven play and a data company. And we have 9 objective databases on pain.
Which I have to believe each person experiences pain differently. And so you use really a scientific method to collect that information, to your point, to create those benchmarks, because someone may have a massive tolerance, someone may not, but they still have the same need. And it's just how it goes about being treated, ideally in ways that don't lead to addiction and other outcomes that we're also trying to avoid. So you're getting in front of multiple problems with your solution.
We are. And, in terms of your comment about the variance, I mean, pain is one of our most subjective measures in all of medicine. And so it's time that we had data around it. And in terms of just the subjectivity, I would mention to you, I actually sat through 300 intakes in the emergency department when patients present to the nurse in triage and tell them their level of pain. And it's all over the map. You've got, seniors saying that they're 10 and they're having a really nice conversation with the nurse. You're having others who are saying, like, my baby, if I say I'm a 7 versus a 5. So what we're currently doing needs to be upscaled in terms of data so that we really have a common bar around the measurement of pain so that we can actually help our patients really achieve the outcomes that they're looking for and also reduce spend in healthcare.
I have to believe, Martha, there's an element of the honesty of the measurement that comes from your solution that to a degree also removes what I would call the shame factor for the patient. Because to your point, maybe it is an 8, but you only want to say it's a 4 because you're either embarrassed or I've just seen so many times in our industry where people are embarrassed to talk about something that is not their fault, but they don't want to have the stigma attached to it that they're seeking something through this chronic pain management as an example. And so you also remove the burden of shame, if that's even a way to explain it, for patients who truly need your help.
Right. Yeah. And I think what we learned is that people are interested in a data-driven conversation, both in terms of how they feel and how they're expressing, but also in some cases the bias that they're feeling from the individuals and clinicians that they're interacting with. And so having a way to sort of validate how they're feeling becomes really important to patients in terms of their care journey.
You had shared in a conversation we had that physicians transition from decision makers to influencers once they get employed by a major corporation. How does that influence also think about how you design and position solutions for health systems?
Right. So the market has changed. 80% of physicians work for Optum, private equity, or healthcare systems. And so I apologize to my physician friends, but when you have sold your practice, you are no longer a decision maker. You're an influencer, but you're not a decision maker. And it's really the C-suite in those organizations that are now making decisions about the scaling of innovation, the acquisition of innovation, and priorities around innovation. And so as vendors look at approaching this new marketplace, it's really important that they understand that difference. So both our healthcare systems and our health plans make decisions both around clinical utility and financial or economic utility. And so it's important to tell a story around both of those themes because that's how technology will be evaluated and how strategic decisions will be made. And so that new landscape is important in terms of that interaction between vendors and those entities that are making the decisions because of how the market has changed over time.
And we're seeing now more than ever that clinical and that financial driver has to be hard ROI. It has to be within a year. And you were on a recent Becker's think tank. What are some of those challenges in selling independent solutions directly to hospitals? Because those point solutions and an innovator having the best solution that's not part of the EMR, but maybe it integrates all those different components. How do they actually get through some of those systemic hurdles to even have their product be seen and heard for evaluation?
Yeah. So let me address the first part in terms of what we're doing. So in that Becker call, we were talking about what's working and what's not working. And so what's not working for us is to approach healthcare systems directly, to try to sell them one at a time. And that's because at a macro level, healthcare systems will tell you that they're interested in innovation. But unfortunately, all of their internal processes aren't aligned with that strategic initiative, right? So it'll take you 10 months on the low side to 18 months on the high side to sell them. They don't stratify based on risk and spend. So a low risk decision that's low spend goes on the same conveyor belt that a very high risk, high spend decision goes on. So you get caught up in those processes. And from our perspective, there are strategic levers that we're using to reach our hospitals that don't require us to sell to them directly one by one. So let me give you an example, or maybe two. So health plans and hospitals that we consider our tier 2 customers. Tier 1 is the government. It's also work entities that work with work comp carriers and insurers of hospitals. And then the third is actually an org that works with biotech, pharma, and device. So on the insured entities that insure hospitals, one of the things that's happened in the last 18 months is 3 of our healthcare systems have been sued for pain. And these are massive lawsuits, 150 on the low side, 250 million on the high side. And our healthcare systems just don't have that data to defend themselves. So entities that insure hospitals will be going to those hospitals saying, you either get this data and technology that measures pain, or your premiums will change because you are high risk now. You have no ability to defend yourself. And there is technology out there in the marketplace to assist. You can, your decision, but if you want to defend yourself, you need to have better data. And this is a means of doing that. So it's a strategic lever. It's a way to reach hospitals without, selling them one by one during a time where they're really distracted. There's a lot going on for our healthcare systems right now, whether it's government, whether it's their communities, whether it's, staff and burnout. They have a whole host of things. So from our perspective, it was just a better way to approach the market by using strategic levers to reach them versus getting into that macro issue of, yes, they're interested in innovation, but processes just aren't aligned with that.
That is very helpful based on the fit of the product in the marketplace because you see a little bit of everything come through the UCLA Technology Development Group. And I'm curious how the Innovation Hub can help structure and incubate ideas and commercial pathways that maybe it is through a VAR, maybe it is through the direct CIO, whomever. How do you help them decide how to go after their market?
Yeah. So UCLA has done a really masterful job of having the whole spectrum around research and innovation. So obviously they've got IP and research that's coming out of the university, and board members will advise on whether or not, oh, this is a company, oh no, this is just an add-on to something else. So we'll give some perspective on that. But in tandem with that IP and research, they incubate companies. So they've got a variety, they've got several innovation funds where they will fund technology and research that's coming out of the university. They have one of the largest conferences UCLA does called LA Best. It's MedTech and Life Science. It's a 2-day conference. They have more than 1,000 attendees, both domestic and international, where they'll bring together all of those stakeholders, the funders, the companies, the entities, the government that will be interested in what's going on. So they're sort of fostering that innovation in a really collaborative way. What I've loved to see is that everybody plays well in the sandbox and everybody in the sandbox is invited. And so Los Angeles is very much that kind of community, whereas some other communities are not quite that way. So it's really been a very collaborative process that they've had. And then the last thing I would mention is, on the research side, UCLA has understood that it's not only the very typical clinical utility research that's needed, but it's also an understanding of the real world data research that's needed. And so maybe an example here. So UCLA recently did a real world deep dive on AI scribes. So they had 2 AI scribes that they were looking at. It was an 8-week sort of pilot. One group of physicians used one AI scribe, another used another AI scribe. They were looking at clinical utility measures as well as economic utility measures. And this was in a public conference, so not sharing anything that isn't in the public domain. So what they identified is that the clinical utility was pretty close on these particular solutions, the 2 that they looked at. Economic utility, no, there was a difference. And so they made a choice that was a little bit more on the economic side because the clinical utility was so similar. And so they understand that our healthcare systems are needing data around real world data because, and I would actually submit to you, that's more important than just some, 30 patients in a study, because that's where we're looking at bringing this, right? So if it works in the real world, we know that if we have the right parameters, that we can scale this as opposed to something that's just done for 30 patients in a, little tiny clinical setting. But it's an understanding of that. So it's the spectrum that UCLA's technology development group is focused on. And I think it's really a well-crafted program for not only the domestic audience, but I think the international audience as well.
Do you get a sense that with our current international relationships that are evolving daily in some cases, that there will still be that drive and that desire to want to have that level of international collaboration on things that are universally applicable, such as healthcare and pain and scribing, etc.? Like, is there still going to be that desire to solve things at a global level that are occurring everywhere?
Yeah, thus far, I've seen that to be the case, where there's still that desire to collaborate. In fact, UCLA had a recent announcement where it was a country from Asia, where they were deepening their ties around innovation and research. So we have continued to see that evolve and advance. I think part of it is that, UCLA is our #1 public university. I think it's just of that caliber where there's interest in the work that is being done. And thus far, we haven't seen that drop off.
Well, and you and I are Californians, and we could also say California matters. It's like, and you don't really want to mess with California. And next of most conversations, we just throw it out there. I'm like, you're welcome. It used to be, oh, California. I'm like, hey, we're still here. We're still a big deal, as I like to say. Also, as a Milken thought leader, what does that platform enable for you, and how do you bridge government, university, and private sector innovation and conversations?
Yes, so the Milken Institute has, I think, done a very strategic deep dive in understanding what needs to occur from a think tank perspective in the marketplace. So they actually really bring together around a focal topic of interest the stakeholders. So it might be innovators, it might be employers, it would be funders, it would be the government. And that whole group is sort of focused on a particular area of interest with the desire for an actionable approach beyond those conversations. So it's important that everybody understands and has a common theme of understanding of that particular strategic issue. But it's really focused on, okay, now that we understand it, where do we take this? What action? So I've been involved in conversations around mental health. So that is of deep concern to our employers and to really everyone who has been touched or has identified for themselves some need of support in mental health. I was on a call a few weeks ago where we were focused on the rate of cancer in our young adults and how that's growing. And so that's of concern to our employers, right? They're seeing those cancer cases rise. What are the common themes and what are some things that can potentially be done by stakeholders in the marketplace? And a third one I would tell you, I think, is women's health. I think there's a great interest in women's health and in having the kind of research and information that's necessary to really advance the outcomes of women that really historically has not been the case. So those are three different use cases of bringing together those entities with the goal of action.
I feel like you've touched on all the perfect sort of hot buttons in people's lives because if pain's hard to quantify, try being over 50 and be a female and what that journey looks like. And I find myself drawn into those conversations more and more, not only because I'm that person now, but also because how hard it is, even as an insider, to get the care, perspective, and even the conversation that you need so that you feel like you can be the best version of yourself. It is really hard to find the right physicians dedicated to women's health, especially again, once you start getting to be over 50. It's a journey for sure. And I love that you're helping to like lead those conversations. And like I said, I keep getting drawn into them more. And I'm grateful for it because I feel like I can give a first person narrative about what it's like. And here, you and I again, we're on the inside and it can be really tough. I want to flip though. Oh, sorry, go ahead.
Just going to add, one data point around this that I think it helps us as it pertains to pain. 80% of pain research was done on human men and male mice. So women are barely in the data. And we have two databases on women in pain, one on women in pain and one on maternal health and pain. And so it's really important that we understand what that looks like for women, because they're basically not in much of the current research. So if we want to understand all of the different things that women go through, it's important to have a lens around their experience.
And funny enough, you talk about shame associated with certain aspects of healthcare. I have no shame in explaining what it's like to just be aging because I think my mom and my grandmother said, hey, it's for the birds. And by the way, here's what happens to you every decade. Well, sadly, they both were gone before 80. So I'm like, what happens? You kind of need like a milestone marker. This is going to happen next. Here's how you're going to feel about this. And working through all the parameters. But I want to flip and put a little bit of education into some of the new CMS models, the team and the ASM one specifically. I'm going to ask you some questions about that. So CMS team model, transforming episode accountability model. It's a mandatory 5-year episode based payment model launching January 1st of next year, running through December 30th of 2030. This targets surgical episodes like joint replacement, spinal fusion, hip and femur fractures, with hospitals accountable for cost and quality across a 30-day post-discharge window. That's the first one. And then the second is the ambulatory specialty model, mandatory outpatient model, which starts January 1st of 27 through December 31st of 2031, that focuses on chronic conditions, specifically low back pain and heart failure, and holding specialists responsible for outcomes and cost with performance data, transparency, and two-sided risk. So with all that being said, as these CMS models shift hospitals and specialties toward episode and condition-based accountability, especially where data matters, even if it doesn't require the FDA approval, how is AccendoWave positioned to lead?
So I think we're positioned well to lead. In terms of the team model, which, as you mentioned, starts in January, so many of those are around spine and joint work and procedures. And we have a MSK and pain database. So in that database, we've got hips, knees, shoulders, and backs. So we've got benchmark data on MSK procedures. So benchmark data, and then individuals can be measured against benchmark. And so there will be more data points to inform what might be the right care journey for this individual, because we now have data around how they are feeling their pain versus benchmark data. And so, under a value-based world, there will be more incentive to really understand which direction patients should go, as opposed to they all or many of them go the procedure direction, right? There may be other options that would be preferable or a better match for their personalized care. So I think we're well positioned for that. I mean, under a value-based care arrangement, when pain is your biggest driver of cost, might be a good idea to get some data on your primary driver of cost now that you're on the hook. So I think that will be necessary. And then in terms of the low back pain in 2027, when we currently got this MSK database, but we are working with a strategic partner so that we will be developing the largest global database on low back pain. And so that probably will be available, I think, in that 2027 time frame. And so then we'll have specific low back pain that can be used as a data benchmark and metric so that patients understand what their level of pain is compared to benchmark, and the clinical team who is incented to work together to really understand the best personalized medicine approach for this particular individual. So I think for both of those initiatives, we are well positioned, and it's really easy to access our technology. We're on the Datavant platform, which is one of the 3 top data platforms. You can share data in a HIPAA compliant way. So it's a very low lift to access that kind of data that can begin to be used to help better inform the care journey.
So that aspect of helping hospitals manage risk, coordinate care, measuring outcomes, all goes back to that $250 million lawsuit. You get in front of that well before it becomes a mandate to understand what's happening. But there's even beyond CMS. There's initiatives like NIH's Backpack for Low Back Pain. There's the Washington's Low Back Pain and Implementation Collaborative. I'm curious how AccendoWave and even some of the institutions through like UCLA that you help advise, that promoting these integrative modalities and care pathways, how does it become part of a common conversation where there's the clinical space and the financial, and there's you could almost put this into a regulatory bucket, but it's more than a regulation. This is actually changing the way we think about providing care.
Right. And we are big fans of integrated modalities and of the different choices that exist in the marketplace. For many of those, there's not been historically a great reimbursement pathway for them, and that has limited the uptake. But I also think it's important to have data around each of those modalities so that we can understand what's working well for that patient and maybe what's not. And so what might be a better choice, as opposed to saying, no, you don't get it. It's like, okay, let's try this foot. We did 3 of these or 3 or 4 weeks of physical therapy. That hasn't been effective for you. Do we really need to do 6? Maybe not. So maybe we can look at other options in that care journey, and not all of those options have to be, procedures and surgeries. There's a real place, and our integrated pain programs are doing a really good job of trying to have those modalities available in a slightly challenging environment where not all of them are reimbursed in a very efficient way. But I also think the day will come where we will have a database on acupuncture. We will have a database on physical therapy. We will have one on cognitive behavioral therapy. And so we'll begin to have benchmark data around that so we can see how someone's doing according to benchmark, and then have that inform in the best possible way a very personalized medicine approach to those individuals. And I think both our research, you asked about UCLA, our research institutions will help in terms of that real world data as well as research.
You talk about data packaging as really one of those core value levers. How can an innovator gather and present clinically and financially convincing evidence, especially for chiropractic, acupuncture, massage, psychiatry, heck, I'll even throw in hypnotherapy, that normally bypass FDA approval?
Yeah, I think it's important for those entities to look beyond or add to historically what they've used as a part of their data package, right? They may psychosocial, there are a variety of things that they're looking at as a part of the packaging of the information. But historically, it hasn't necessarily been around objective data. It's a patient reported data, which is very important, but I think we need to have both. And so there's an ability to go to a data platform like Datavant and access that data and use that data in tandem with what you're currently doing to strengthen the case for reimbursement for those modalities in a more significant way than what we have today in our marketplace. Because I think historically what we have done has not been sufficient, right? So I think we have to change what we're doing and utilize that innovation to enhance that data packaging picture and story so that those who make those reimbursement decisions have the package that they need in front of them that's de-risked because you've provided all the data that they would need to make that decision.
So I'm going to stay on the de-risking topic only because what strategies are effective do that for hospital adoption when navigating all the tiers, the government, the hospital, the payer, biotech, pharma, you named them all. How do you effectively de-risk that for a system?
Yeah, so I think there are three things that help de-risk that for a system. The first is really having data, whether it's both research and real world data. I think they do need real world data. I mean, just as UCLA did their own internal study because they needed to understand what the economic utility and clinical utility was for them, I think that kind of data will be important. Secondly, I think deployment expertise is so important in terms of success with our healthcare systems. So, remembering my HCA days, it was rare that we had a technology that just didn't perform by the time it got to deployment. What typically went wrong was the deployment process and post-deployment process. And so I would tell you that there is a secret sauce to deploying in our healthcare systems. Unfortunately, we don't tell our vendors what it is. We just expect them to know. And then we're a little bit disappointed when they're high maintenance and it's not a low lift as we expect. And so having that deployment expertise, understanding that there's a pre-deployment phase, that there's a soft launch phase, that there's a full deployment phase, and then there's a post-deployment phase. And having the acumen so that it's really a light lift. And I remember one comment from an HCA CEO and it was just, I love this comment. He said, we hardly know you're here. It is such a light lift, whereas that's not our typical experience. And so you have to think through every touch point for every individual and minimize it because we just don't have a new team that arrives when we deploy. These people already had full-time jobs and now you've just added 10% to their workload. And so you have to understand each of those stakeholders and how you create that seamless deployment so that you get those kinds of comments. And then the last thing that I would mention, Sarah, is that, and people don't talk much about this, so I think this might be a sort of a unique perspective, but I'm not sure if you were at HCA at this point, but I was at HCA during the point where the Malcolm Baldrige Awards were created it was the first year for healthcare. So actually HCA was a co-finalist in the Malcolm Baldrige Awards, and I was involved. And one of the things we learned through that process of doing that Malcolm Baldrige work is that doing business, whether it's internally or externally, is really a series of handoffs. And how well that business goes is reflected on those handoffs. And so we called it our customer supplier alignment, making sure internally as well as externally. And for externally, I would tell you that when I think about vendors, I can think about maybe 5 or less who asked me the right questions so they were a successful deployment. So our vendors make a lot of assumptions about what they think we want. And they don't point blank ask us the key 3 questions. So I'll just give you one. First one is, what do you need from me? Well, I need data from you. Well, what kind of data do you need? I need pain data. When do you need that data? I need it weekly. Who gets that data? Oh, it's these 4 departments and the whole C-suite. And so they need to ask really strategic, very direct questions so that you don't see a scenario where pilots go on for years because they haven't asked the right questions to understand what gets them out of pilot. Like we were out of pilot 6 months and a day. We knew exactly what we needed to do. We provided data every week. It went to this group. These were the measurements. We knew exactly where we were and because we asked those questions. And our vendors would distinguish themselves if they would ask these questions so that they are very clear on what's needed to deploy successfully. And those are the strategies, along with the expertise and having data, but really understanding what is needed for a successful deployment, post-deployment, and multi-year relationship where you co-lead the innovation together.
Those partners are fewer and far between in some cases, for sure. And to your point, having spent a decade at HCA, you got very specific about how we did things there, which is why we were able to do things, I believe, pretty darn efficiently. We picked something, we knew how to systemize that no matter what. What I have found post-pandemic, and I'm really curious your thoughts on this as well, is that everyone got very focused during the COVID initial epidemic, and we were able to do certain things very well. And now we're back to 300 projects in the pipeline in the portfolio. We've like lost everything we've learned about that. How do you start to reel people back in and say, look, you can't do 300 things at once. Otherwise, you just have this perpetuity of pilots and even failures in some cases because you don't get to hone in on the things that are most important that we've been talking about today. If you could give advice to listeners to say, here's how you get back to getting it right, what would you ask them to do?
So, scale of the problem. We don't have the capital or the resources to solve all of our problems, but we can solve the ones that are the most important to us. So, you have to be very clear on what are your top 3 to 5. And then if you can do something beyond that, great. But top 300 is probably not a good idea. And then beyond that, in terms of, your roadmap and your process, I think you have to have data and metrics around it so that you can be successful with those projects. And we have to have data and metrics around our internal processes. I mean, we can't continue to do a scenario where, a vendors of interest. So it takes 8 to 12 weeks to schedule a meeting because everybody has all these standing meetings. And then we bring in a vendor for 20 people, which isn't necessarily the best process because our introverts in the room never ask a question. And so we need to look at different, like maybe it might make sense to have a vendor come into the admin conference room after 2 weeks and send the departments down to visit with them when they're available over that 3-hour period so that all the introverts get their questions answered. It's a much better experience for everyone. And we can pull, 10 weeks out of the sales cycle for our vendors. But we also have a metric very quickly around whether or not this is of interest to our staff. So I think we have to look at what I've heard employers describe as administrative bloat. And I think that we have to look at what are our processes where we have administrative bloat and where can we refine them, just like the contracting, right? Does everybody need to go on the same conveyor belt, or can we stratify and have different paths and different processes for those so that we can be much more efficient? And I think we don't have the luxury of time anymore. I think the market is moving very quickly. And so I think we have to look for those opportunities to identify internally what can we change, and maybe we could refine these standing meetings a little bit, because we did that during the pandemic, right? Those flipped down in a pretty significant way, and now they're sort of creeping back up. And so I think it's important that we continue to use that lens of efficiency around what we're doing, which makes us, which reduces spend and cost and time and all of those good things, and employ those moving forward, as opposed to it happened during this very minute period of time, and then we went back to old practices.
Because we know it can be done. That was the thing about it. Illustrations. There were silver linings in anything that happens. And I'm like, we were really good at getting stuff done because we didn't have too many things to do at the same time. And yet now all we do is talk about what it was like then, et cetera. And so, but history is always creating itself in the moment. And so what do we learn from an experience such as that? I want to ask you a visionary question about how you see AccendoWave's impact by 2027 or 2028. And what role will UCLA and your Milken and Becker's engagements play in shaping that landscape?
So by 2027, I think there will be entities that will be incorporating objective pain data, and it will be pushed down by sort of strategic initiatives. So I think you will see that, because entities don't have any objective data, and it's clear that the time has come. So we need data. just because of the spend that's occurring. I think in terms of UCLA, I wouldn't be surprised if they were involved in some pain research projects. In terms of Milken, I think there's a real desire to focus on the Women's Health Initiative. And so I think you'll see some traction there and some movement. And obviously, given the fact that we have data on women in pain, we think that there's a nice match there. And then, you mentioned earlier sort of being on a Becker collar too. And that is, I think we have to be very clear about what's working and what's not, and sort of move forward with the things that are working and really sort of pushing aside those things that aren't working. But I think by 2027, we need benchmark data. People don't have benchmark data. And so it's important that it exists and it be used. So I think I had a crystal ball. That's where I'd point it.
Well, and I'm glad we get to keep talking about it as well. Last question for you, and that is, if our audience walks away with one key insight about scaling innovation, where data, not necessarily FDA clearance, is the currency, what would you want it to be?
So I think we need objective pain data. I think that's the currency that we need. We need that to address pain bias. So our moms of color, our brown moms and our Black moms, are not getting less pain medicine than our white moms. And that we no longer have a scenario where the number one complaint of our Black patients is that their pain isn't believed, and they are getting later stage cancer diagnosis because of that pain bias. So I think that's needs to be a part of that. And then we need data on one of our biggest cost drivers. We need that data to reduce spend, because we know that we can't continue on the direction that we are currently facing. So we need data-informed decisions that reduce our spend. And so that would be my walk-away point. We need objective pain data.
And I love that everything you're working towards has an element of health equity to it, because so often so many people get left behind by the healthcare system, and you're making sure that doesn't happen. So thank you for that.
Yeah, thanks.
And most importantly, thank you for your incredible insights. You are truly reshaping how data drives innovation in healthcare, all from the vantage of institution, policy, and entrepreneurship. Thank you for being on the show today.
Oh, my pleasure, Sarah. Wonderful conversation. Thank you for the opportunity.
Of course, and always, thank you for sharing your powerful insights, practical wisdom. And this is from scaling innovation at AccendoWave to shaping research and investment strategies at UCLA. Today's conversation is a reminder that true leadership is about influence, foresight, and the courage to rethink how data can drive healthcare forward. If her vision of leveraging innovation and packaging data to accelerate impact resonated with you, please share this episode with your colleagues. Start a dialogue about how we can scale smarter and explore how you too can influence change. And as always, keep flourishing. That's all for now. Thanks for joining Flourish. Remember that every healthcare leader needs a community to learn from and to lean on. Find your people at thisweekhealth.com/subscribe. Share this episode with someone who needs encouragement today. Keep flourishing. That's all for now.